My task today is to defend the hemoglobin A1c as a good target in the treatment of type 2 diabetes subjects. Even if I stated here that I have no disclosure related to this lecture, in fact I have one disclosure, so I will not try to convince you that hemoglobin A1c is a better target than cardiovascular risk reduction. I will just try to show that they are equally important. And I'll start by saying that discussion is an exchange of knowledge, and an argument is an exchange of ignorance, but I'm convinced that with Professor Lalic we'll have just only a friendly discussion about this topic. So this is the agenda of my presentation, and just to start with some background data, we all are witnessing the explosion of diabetes worldwide, and the latest IDF 2019 data make the prediction that in 2045 there will be more than 620 million persons with diabetes, and to be honest, all predictions made by the IDF were highly surpassed by reality. And we all know that diabetes becomes a dangerous disease through its chronic complications, either cardiovascular or microvascular, and these complications are generated by the repeated acute changes in cellular metabolism and also by the cumulative long-term changes in stable macromolecules, and these take place through the famous 4 pathways of chronic complications, which were postulated by Michael Brownlee almost 20 years ago already. And again, we all know about the micro and macrovascular complication of diabetes, but the main focus of our lectures today will be the cardiovascular complications, and the estimates of the IDF say that people with diabetes have a 2 to 3 times higher risk of cardiovascular disease compared to the non-diabetic population. So, the second part of my lecture is related to the question if diabetes is really a coronary heart disease equivalent. And the story began, of course, with the famous study of Stephen Hafner, published more than 20 years ago in a New England Journal of Medicine, and that study showed that patients with diabetes without a previous myocardial infarction have an equally high risk for a second MI compared to patients without diabetes but with a previous myocardial infarction. This was a very impact story in the diabetologic community, and maybe every one of us adopted this idea, but the studies conducted in the following years came to show that not necessarily diabetes is a coronary heart disease equivalent. This is mainly true in patients with a long evolution of diabetes, with a long evolution of atherosclerosis and so on, but is not true in younger patients with recently diagnosed diabetes. And there is an interesting meta-analysis published 10 years ago in Diabetic Medicine, which included 13 trials with more than 40,000 subjects that were followed up for a mean of 13.4 years. And the analysis tried to see if diabetes is really a coronary heart disease equivalent, and the result was that patients with diabetes without a prior MI had a 43% lower risk for a total coronary heart disease event compared with non-diabetic subjects with a prior MI. And the latest estimates worldwide regarding the prevalence of cardiovascular disease in diabetes are that around 32% of subjects have already cardiovascular disease, the majority of them coronary heart disease, 21%, 10% with a history of MI, and 7.5% with a history of stroke. Let's move now and see what is the effect of glycemic control on the occurrence of diabetes complications. And this is a very interesting trial published recently from the United States, the so-called Diabetes and Aging Study. This included a cohort of newly diagnosed type 2 diabetic subjects that were followed up prospectively for a median of 7 years, and the study analyzed the correlation between the exposure to different levels of hyperglycemia reflected by hemoglobin A1c lower than 7, between 7 and 8, 8 to 9, and higher than 9%, and the occurrence of microvascular and macrovascular complications of diabetes. And as you can see, exposure for 7 years to a hemoglobin A1c higher than 9% leads to a 6-time higher risk for developing microvascular complications. There is also an increase in the risk of macrovascular complication, but the magnitude is lower, so this is only a doubling of the risk for patients having a hemoglobin A1c higher than 9 for 7 years. We cross the ocean, and data from Sweden, another famous study published in 2018 in New England Journal of Medicine, analyzed the risk factors associated with mortality and cardiovascular outcomes in type 2 diabetic subjects. And very interesting for us is that glycemic control reflected by hemoglobin A1c seems to be the most important factor associated with the risk of MI, and the contribution is stronger than systolic blood pressure and LDL cholesterol. And the same is true for stroke. Again, glycated hemoglobin is the main contributor, and this is followed by systolic blood pressure and duration of diabetes. If we are talking about type 1 diabetes subjects, we have data from the famous DCCT and EDIC trials. And again, hemoglobin A1c, so glycemic control, represent very important predictors of the risk for cardiovascular disease and MACE events. And hemoglobin A1c is surpassed only by age in this group of type 1 diabetic subjects. But it is stronger than lipids, even than smoking and hypertension. Okay, so we have epidemiological data that hyperglycemia and bad metabolic control is a major risk factor for chronic complications, but do we have evidence that by treating hyperglycemia we succeed to reduce the risk of these complications? And of course, in type 2 diabetes, the story starts with a UK PDS trial that showed that a good glycemic control by intensive treatment of glycemia leads to significant reductions of the microvascular endpoints, mainly retinopathy, 21% decrease, and the renal disease evidenced by microalbuminuria with a 33% reduction. But yes, we know that the effect on cardiovascular disease reflected by the incidence of myocardial infarction was reduced by only 16%, and it was not statistically significant during the randomized phase of a trial, but still the long-term follow-up of the patients in UK-PDS showed a trend for protection over a long time. Okay, I'll move now to see what are the trends in the evolution of diabetes complications worldwide. And the truth is that we were quite successful in the last 10, 15 years in decreasing the prevalence of cardiovascular disease and mortality associated with cardiovascular disease, at least in developed countries. And perhaps we succeeded to do this mainly by treating lipids and by treating hypertension and so on, and maybe not so much by treating hyperglycemia. So these are some data from the United States, and you can see a continuous decline from 1998 to 2014 for heart failure admissions in hospital, for acute coronary syndromes, maybe not so much impact on hemorrhagic stroke and arrhythmias. Regarding mortality, data again from the United States show that if 20 years ago, half of the patients deceased by cardiovascular causes, there was a continuous decline in mortality associated with CVD. So 5 years ago, only 1/3 of type 2 diabetic patients died due to cardiovascular disease, and the majority to non-vascular and non-cancer conditions. These were the data from the United States, but we have similar data from Europe, and this time I'm talking about Sweden again, because in the Scandinavian countries, you all know they have very good registries of chronic diseases, including diabetes, and as you can see, the columns in red, there was a continuous decline during the last 20 years in mortality, in cardiovascular disease mortality, in mortality associated with heart disease, and in hospitalizations. But the truth is that the risk remains double compared to the matched non-diabetic controls. So still we have a lot to do to improve the outcomes of our patients. Talking about all-cause mortality, you saw the data from the United States, the data from Sweden, and you can think that, okay, US and Scandinavia, they have very good medical systems, they are very rich countries, but you can see that worldwide the trend is similar, a reduction in mortality. What about the microvascular complications of diabetes? And we all know that to prevent microvascular complication, to prevent eye disease and blindness, to prevent neuropathy and amputations, to prevent chronic kidney disease, maybe the most important thing is to control hyperglycemia. So I'm presenting some data from the International Diabetes Federation and also from the USA regarding the burden of diabetes and its complication in US. And you can see that there was an increase in the number of severe vision impairment, an increase from 1.3% in 1990 to 2% in 2010, and 25% in the proportion of blindness associated with diabetic retinopathy from 2.1 to 2.6%. And the latest data from the US show that almost 12% of patients have vision disability, including blindness due to diabetes. Moving to chronic kidney disease, the latest estimates from the USA show that almost 40% of patients have chronic kidney disease associated with diabetes, and half of them have stage 3 or worse chronic kidney disease. And regarding the latest stages of end-stage renal disease, 40% of end-stage renal disease in the USA is directly attributable to diabetes, and this is larger than hypertension and glomerulonephritis, and the costs are doubled or even tripled by the presence of end-stage renal disease and renal replacement therapy. Of course, people with diabetes live longer nowadays because we are treating them better, and maybe we are controlling better the cardiovascular disease. So people are not dying any longer at a young age due to myocardial infarction and stroke and so on. But in this way, they are living enough to develop chronic kidney disease and have the time that chronic kidney disease progress from early stages to end-stage renal disease. And this maybe explains why worldwide there is a continuous increase in the number of patients reaching the stage of end-stage renal disease. And another interesting article published recently from Canada showed that in hospitalized patients, the proportion of patients with diabetes versus non-diabetic patients is 4 times higher for chronic kidney disease and 12 times higher for end-stage renal disease. Why I insisted a little bit on this renal disease story, it is because renal disease is really considered today a cardiovascular disease equivalent, and not only equivalent, but it multiplies several times the risk of dying from cardiovascular disease causes. And just to exemplify this, I'm presenting some data from the Carmelina trial. The Carmelina was the CVOT of linagliptin, and it was particular in the landscape of cardiovascular outcome trials because it included a large proportion of patients with chronic kidney disease, almost 75%. And a third of the patients had concomitant CKD and CVD. And which were the outcomes? I'm presenting on this slide the MACE rate in the placebo-treated patients in several CVOTs, including Excel with weekly exenatide, EMPA-REG with empagliflozin, Harmony with albiglutide, Elixa with lixisenatide, and Carmelina. The event rate in the placebo arm really reflects how sick these patients are, and you can see that there is a continuous increase in the rate of major cardiovascular events, and this is proportional with the frequency of CVD at baseline. So the event rate was lower in Excel, where only 73% of patients had CVD, and it increased to 6% in Harmony, where 100% of patients had CVD at baseline, and even 6.3% in Elixa, where 100% of the patient had acute coronary syndrome in the 6 months preceding the inclusion in the trial. And you can see that in Carmelina, with only 60% of patients having CVD, but 75% of patients having CKD, the event rate was similar with that in Harmony, where 100% of patients had CVD. And of course, we can prevent renal disease by good glycemic control, and there are strong data related to that. And the meta-analysis published 8 years ago showed a 14% lower risk for the development of microalbuminuria, 26% lower risk of progression from micro to macroalbuminuria, 31% decrease in the risk of end-stage renal disease associated with an intensive glycemic control. Now I shall move to some thoughts that arise from the famous studies of intensive glycemic control like UKPDS, ACCORD, ADVANCE, and VADT, and the more recent data from the CVOTs of modern diabetes drugs, and see how the results from these studies compared to each other. And starting with the intensive glycemic control trials, this is a famous meta-analysis published by Turnbull more than 10 years ago, which showed that intensive glycemic control is associated maybe with a higher risk of mortality, but this was due only because of the data in ACCORD, and overall these were not statistically significant, no effect on stroke, but there was a significant 15% lower risk for myocardial infarction associated with intensive glycemic control. Another larger meta-analysis published by the Cochrane database showed a similar reduction in the risk of non-fatal myocardial infarction, and the reduction was of 13%. Regarding the risk for the composite MACE, cardiovascular mortality, non-fatal MI, and non-fatal stroke, there was a 9% lower risk associated with intensive glycemic control, and this was not statistically significant, but you can see that it narrowly missed the significance. And we all know that maybe on a longer term, intensive glycemic control, especially if early initiated after diabetes diagnosis, will bring cardiovascular benefits, and this was evidenced in UK-PDS with a reduction of the risk for myocardial infarction, but even in VADT, where the patients included had long-standing diabetes and already a large proportion of them had cardiovascular disease, over the long term, it was a significant reduced risk for a cardiovascular composite endpoint. Okay, moving to the modern cardiovascular outcome trials, we all know the beneficial effects of GLP-1 receptor agonist and SGLT2 inhibitors, but let's see which is the magnitude of the effect. And the latest meta-analysis of the two modern classes are represented by the Christensen et al. In Lancet for GLP-1s, and the Arnott et al. In the Journal of the American Heart Association for the SGLT2. And you can see that the reduction of the risk for the MACE in patients with established cardiovascular disease is 14% for the GLP-1s, and similar 14% for the SGLT2 inhibitors. But talking about patients who do not have cardiovascular disease, so the so-called primary prevention, the reduction is more modest, only 5% for GLP-1s and 6% for the SGLT2s, and these were not statistically significant. And another meta-analysis published recently, again in the Journal of the American Heart Association, tried to compare the magnitude of the benefit from the intensive control trial versus the modern CVOTs, and you can see that overall the reduction was 9% for the intensive control treatment of hyperglycemia. It was 11% for the SGLT2 and 12% for the GLP-1s. Of course, this is a little bit better, but come on, 9% versus 11%, I don't think that this is so much clinically relevant. And another story and interesting thing for debate is a interesting article published recently by a Japanese group highlighting that in the modern CVOTs there is an imbalance between the level of glycemic control in the placebo arm and in the actual treatment arm, and this ranges between 0.3 in TICOS and SAVOR, and it reaches almost 1% in SUSTAIN 6. So overall, the mean difference in hemoglobin A1c between the placebo and active treatment was of 0.42%. And the authors, of course, they only raise the question and the hypothesis. They say that maybe the efficacy, protective cardiovascular efficacy of the new agents is potentially inflated because the difference in hemoglobin A1c, and maybe reanalysis and adjustment for hemoglobin A1c should be done to have a better vision about the efficacy of these drugs. And this is what the meta-analysis in the Journal of American Heart Association is trying to do. So the estimate for the difference in A1C in the intensive glycemic control trials was of around 10%, and this was associated with a 9% lower risk for cardiovascular events. In the CVOTs, the mean difference in hemoglobin A1C was of 0.42%, and overall the risk reduction of the risk was of 8%. And by a meta-regression analysis, the authors suggest that if the difference in A1C was similar in the CVOTs with that recorded in the intensive glycemic control trials, the benefit expected in the modern CVOTs would be much higher at 33% risk reduction. Of course, these articles and meta-analyses are only hypothesis generating and still don't prove that intensive glycemic control is better than using the modern cardioprotective drugs. So just to move to conclusion, the truth is that modern guidelines still use glycemic control trial targets, and the latest example is the algorithm of the American College of Endocrinology and the American Association of Clinical Endocrinologists from 2020. So they include specific cutoffs of hemoglobin A1C to initiate monotherapy, dual, triple, insulin, and so on. They include glycemic control targets, but of course they specify that independent of glycemic control, if you have CKD or high risk for CKD or atherosclerotic cardiovascular disease or heart failure, you should use one of the two modern classes of diabetes drugs. And to finish my lecture, my personal opinion is that both glycemic control and control of cardiovascular risk are equally important, and we have to take a holistic approach to the patient. So not only glycemic control, metabolic control, we also have to look at the lipids, to the non-alcoholic fatty liver disease, to cardiovascular targets like hypertension and so on. And more we have to focus on the high risk which is brought by chronic kidney disease. And this holistic approach of the patient with type 2 diabetes, you all know, was the approach took by the investigators in the famous Steno trial, and the results in the Steno trial are the best to be reported in any trial in diabetes patients until now. So you can see almost 50% reduction in all-cause mortality, 60% reduction in cardiovascular disease mortality, 33% reduction in retinopathy progression, 50% reduction in macroalbuminuria, reduction in neuropathy, and so on and so on. And to finish my lecture, this is my final thought. This holistic approach for the patient with type 2 diabetes, we have to start it not yesterday, but today, as soon as possible. So as this civil rights activist stated, now is the accepted time, not tomorrow, not some more convenient season. Today is that our best work can be done. And thank you very much for your attention.
Thank you, Cristian. I have observed lately you have a growing preference for civil rights activists in your quoting. And yet I want a statement from you. Do you still believe that HbA1c is a valuable target from the beginning in all patients with type 2 diabetes or not?
there is a lot of evidence nowadays that maybe glycemic variability is a better target than hemoglobin A1c. This is for sure in type 1 diabetes, but more and more data come to show that in type 2 diabetes, glycemic variability, even hemoglobin A1c variability, is associated with a higher risk of CVD and mortality. So yes, maybe we have to move from only targeting A1C to improve glycemic variability. But for this, of course, the larger use of CGM monitors is a must. Okay. And at least in type 2 diabetes, this is difficult to implement right now.